We'll just wait a few minutes because nobody has joined quite yet. Some people are starting to trickle in, so we'll give it a couple of minutes. Guess we'll get started in about a minute. People are slow to enter today. It's that summertime vibe hitting, I think. I guess in consideration of time, we can maybe get started. And people will just join. It's kind of a typical thing. So good afternoon, everyone. Welcome to the iRise Above, iRise and Shine Wellness Collective webinar series. My name is Jillian Lashota, and I am the founder and executive director of the iRise Above Foundation, a breast cancer organization created by young women for young women after breast cancer. iRise Above strives to empower young women to establish an outstanding quality of life, providing inspirational support for those diagnosed with all stages of breast cancer and those in remission. Our mission is to surround these young women with targeted, age-appropriate, and connected health and wellness resources and tools to enable them to rise above the residual effects of breast cancer, heal, and live well. This afternoon, I'd like to welcome our guest speaker, Dr. Vered Stearns, co-director of the Women's Malignancy Disease Group and professor of oncology at Johns Hopkins School of Medicine. Dr. Stearns is a board certified medical oncologist in Baltimore, Maryland, and serves as the co-director of the Johns Hopkins Kimmel Cancer Centers for Breast Cancer program. In addition to being an extraordinary clinician, Dr. Stearns co-leads the breast and ovarian cancer program and is the associate director for oncology at the Johns Hopkins Clinical Research Network and associate medical director of the Johns Hopkins in Singapore. As a translational scientist, Dr. Stearns aims to further an individualized approach to the prevention, treatment, and care for people with or at risk for breast cancer. Currently, she focuses on the utilization of biomarkers to predict response to standard regimes used to treat and prevent breast cancer and to introduce new approaches. Dr. Stearns serves on the iRise Above Foundation's board of directors and will provide medical oncology research updates on the advances in treatment of metastatic breast cancer. Dr. Stearns, I am very honored to have you with us today. And without further ado, please welcome Dr. Vered Stearns.
Thank you so much for the very kind introduction. And I'm really pleased to talk to you today. Everything that I try to do in my professional and personal life is to try and improve outcomes of those with cancer and at risk. So any questions or suggestions you have are welcomed. I'm going to start by sharing my slides, but I will say I tried not to have many. I will look at it as more of a broad overview, and then I'm happy to take some questions and stop at different areas to allow you to ask your questions. Started from the back. Sorry about that. You have to see all of my talk backwards. So Jillian asked me to talk today about advances in the treatment of metastatic breast cancer. So just as an overview and a reminder, breast cancer is the most common malignancy in women worldwide. There's 1.7 million, many more today that are diagnosed each year. About 12% of all new cancer cases are breast cancers, and it's about a quarter of all cancers in women. Is the 5th most common cause of cancer-related death in women. Now, it's important, we talk a lot about different subtypes of breast cancer, and I will touch on this briefly, but most breast cancer, about 2/3, are hormone receptor positive. And most breast cancer in Western societies are diagnosed with early stage disease, and many of these women will survive their cancer, but in some women, cancer can recur, or some women are diagnosed initially with cancer that has metastasized, or what is called de novo metastasis. Today, and I emphasize today, 2021, when metastatic, most women with breast cancer will need a series of treatment, and they can live with their cancer. Most women can for years, even decades, but we see few cures, and we can talk a little bit about that later in this conversation. What is metastatic breast cancer? The thought is that the cancer starts within distinct cells within the breast and then can spread via either lymph channels or blood vessels from the breast to either regional lymph nodes or at times to other organs such as lung, liver, bone, brain, and other. Once breast cancer is spread beyond the breast and lymph nodes, we do hope that our treatments can help cure the cancer. But for most women, unfortunately, will not result in a cure, but it can help prolong their life and delay cancer progression. Most women will receive some sort of treatment for their cancer, and overall, on average, women feel better on treatment. It alleviates symptoms from growing cancer cells. We also try very hard to minimize complications that result from where the cancer might be located and provide the longest possible time and with quality. And I want to touch a little bit about breast cancer molecular subtype and some of the nomenclatures that is being used either in the lay or in the medical literature. So, and the reason why is because the treatment and the prognosis, how long one might live with cancer, is different based on those. So beyond that, it's different for every individual. And I'm sure Jillian has heard many of my team members say you cannot compare two stories. Two stories are not alike, as we're all different people. Likewise, our cancers more likely to resemble our own normal cells than someone else's tumor. So we're not there yet in providing the most individualized approach, but that's where we're hoping to be in a few years. So as I mentioned, most breast cancer are hormone receptor positive. What this graph figure pie chart shows is that in the primary breast cancer and metastasis, there are some differences in the subtypes. So in the primary breast cancer, about 2/3 of the cancer we see are what called luminal, either luminal A, which are usually slow growing cancers that have the estrogen and progesterone receptor on them. And then there's a proportion that's HER2 enriched here in pink, a proportion that's basal-like, and then some that look like normal cell. Now, those description, basal-like, luminal, come from more complex testing of tumors than we don't do every day in clinic, although it is possible to do it if needed. So we use other parameters, which you probably all heard about, like estrogen receptor, progesterone receptor, HER2 receptor. And if the breast cancer cells have the estrogen or progesterone receptors, they're luminal tumors usually. HER2 positive are usually HER2 enriched. And those that don't have estrogen, progesterone, or HER2 are called triple negative. Now, as you can see in the metastatic breast cancer, there's more cancer that are HER2 enriched or basal-like or triple negative than in the primary tumor. So those are the implication. And what we hear more about triple negative and HER2 related cancer is that there were traditionally fewer treatments for those than for the estrogen receptor positive cancers. So the way I structured my talk was I was going to talk a little bit about hormone receptor positive breast cancer and hormone therapy, and I'll pause there for questions. Then I'll talk a little bit about chemotherapy, which has implication for all three major subtypes. I'll talk a little bit about chemotherapy, as I said, and about anti-HER2 agents. And then I'm going to touch a little bit on immunotherapy and novel agents, and then I can base the conversation on your questions. I'll remind individuals I see there are always opportunities for clinical trials, and every time there's a need to start a new treatment or change treatment, I would consider a clinical trial. I'll start by talking about hormone therapy-based interventions. There are several, I'd say there are many treatments that are hormone-based for metastatic breast cancer. So again, this is relevant for women whose tumors have the estrogen or progesterone receptor. One of our oldest drugs is tamoxifen, which is still in use at time, aromatase inhibitors, letrozole and anastrozole or exemestane, fulvestrant, which is an anti-estrogen. Women who are still premenopausal will also be recommended ovarian suppression or removal of the ovaries many times with the aromatase inhibitor fulvestrant in particular, and then sometimes with tamoxifen as well. And there's new class of drugs calling selective estrogen degrader, and many of those are pill forms, and I'm excited to see how those gonna fall within our treatment portfolio. Traditionally, we've given a hormone pill or injection at a time, but more recently we've had many new medications that when added to hormonal therapy allow women to live well with their cancer for months or years. The first group, which I'll talk a little bit about, is the cyclin-dependent kinase or CDK4 and 6 inhibitors. And then there are other medications such as everolimus or Afinitor, which is an mTOR inhibitor, and a PI3 kinase inhibitor, alpelisib. And I'm not going to talk very much about the last two. So if you have a question, please let me know. So there's now 3 approved CDK inhibitor. The first one was approved in 2015, and it's palbociclib or Ibrance. The second is ribociclib or Kisqali. And the third is abemaciclib of Verzenio. And there's a little bit of difference in the schedule and how those are given. The first 2 are given for 3 weeks daily in a row, and then there's a week break. The third one, Verzenio, is given every day. And the side effect profile is a little bit better, a little bit different. Now, we don't usually give more than one CDK inhibitor in individuals, but there are some data that people who may have been on Ibrance in the past could benefit from Verzenio later on. And again, happy to answer questions. What are the side effects of CDK inhibitors? Truthfully, most women have a few side effects, but the most common one are low white cell count, which we try to minimized early on by adjusting the dose. About 40% of women will have to have a reduction of the dose, and some will have 2 or 3 additional reduction. Sometimes we see anemia or low platelet count. The other very common one is fatigue, and sometimes women do feel better in the week off on the medications that are given more intermittently. And again, we try to adjust. We do see mouth sores, hair thinning, sometimes gastrointestinal type symptoms, especially with Verzenio. We see a lot of diarrhea, and then the possibility of neuropathy. More rarely, there could be a pneumonitis. So it's important for women to share whether there's a side effect or a symptom they're concerned about. So this is something that I put together some time ago with a couple of my colleagues and tried to modify a little bit. So how do I think about treatments? So women who have a new diagnosis or recurrence of the hormone receptor positive breast cancer would, I would say for the majority of the women, I will pursue the middle column here, which is a aromatase inhibitor and a CDK inhibitor. If it's a premenopausal woman, will add ovarian suppression because the combination has shown that one can live with a cancer on this treatment longer than just with the tamoxifen aromatase inhibitor alone. But having said that, sometimes we do give this medication by itself as well. So I do want to consider it. And the first treatment that I recommend, I would call first-line therapy. And those designations come from how those drugs were studied in which population of women. And then if the cancer has grown on this first combination, we can consider usually fulvestrant or alpelisib if there's a PIK3CA mutation. If not, we think of exemestane, everolimus, and chemotherapy. I was going to move into talking a little bit about chemotherapy. So if there's a question now about hormone therapy or more general question, I'm happy to take that.
Dr. Stearns?
Yes.
I'll read a question from someone in the audience. It's a multi-part question, but I think it all relates back to one of the beginning slides. The question reads, how do we know if you have luminal A or B? Is this the pathology report? It looks like luminal B is more common in metastasis than primary. Does the luminal status have any implications for treatment of primary tumor or prevention of reoccurrence? Or is there a relationship between luminal status and oncotype score?
Yeah, very, very good questions, all parts, and hopefully I'll remember them all. But we don't always try to determine this subtype, which, as I mentioned to you, is just comes from a more sophisticated way that takes more time and costs more to get whether this is luminal A or B. But in general, there are other ways to determine if the cancer is luminal A or B, or if we're not sure, we can get additional testing. So, for example, a cancer, and that's true both in the primary and metastasis, it's a very high expression of the estrogen and progesterone receptor, let's say 80, 90, 100%, and is HER2 negative and has a low growth rate, that's usually luminal A. If the cancer has something that doesn't fit those categories, so if it's fast growing, or if it's doesn't have the progesterone receptor, or if it has, and some of them would also have the HER2 receptor, then it's probably luminal B. And the way we think about it in the primary cancer setting, women who have early stage 1, 2, or 3 cancer, is that the ones that are luminal A, those women may not need chemotherapy in the early setting. So this is, for example, a woman with low oncotype or low mammoprate. So the answer is yes, oncotype can help with that. And those, as I said, we're not sure that this tumor is going to be hormone sensitive. That's when we consider adding chemotherapy, even for the very small early stage 1 breast cancer. But I think what you see reflective in this, on those pie charts, is that we either prevent recurrences of more of the luminal A's. So more cancers that come back are the luminal B's, even with chemotherapy and other types of treatment. And the luminal A's are the one that are most likely to be cured in the early setting with our treatments. So that's where the difference come from. Did I cover all the parts?
I think so.
Okay.
Yeah, pretty good.
All right. So I'm going to talk a little bit about chemotherapy next. And just as a reminder, chemotherapy is relevant to women with hormone receptor positive breast cancer. I just talked to you about the different line of treatment. So if I tried 2 or 3 lines of hormonal therapy, and this could take years, even a decade or more in some women, but if the hormone interventions have stopped working, then I think about chemotherapy, and as I mentioned, also clinical trials. And then also with HER2 positive disease, we do have several anti-HER2 agents, which I'll talk about, but many are given with chemotherapy. And finally, the mainstay for triple negative breast cancer is chemotherapy today. So what do I think about when it relates to chemotherapy and metastatic disease? So as I mentioned to you, it may be given to women with all these different subtypes, the endocrine resistant hormone receptor positive breast cancer, the HER2 positive breast cancer, and then triple negative. The triple negative in particular is a little bit more complex. I told you about 15% or so cancers are triple negative, but even within that, there's probably more subtyping than we need to do. For example, one of the emerging treatments today is immunotherapy, and there's a lot of excitement about this, but in reality, what we know today about immunotherapy in triple negative breast cancer is that only some of those will have the PD-L1 antibody on the cells in the immune environment, and those women may benefit from the addition of immune agent to the chemotherapy. But unlike other cancers like melanoma or lung cancer, we haven't seen very long sustainable benefit to all women with this tumor biology. But having said that, there are some women, remember I told you early on that we don't see a lot of cures. We see some. There's an occasional woman with triple negative breast cancer who has a PD-L1 on the cell, and she receives immunotherapy, and she's without disease for many, many years. And a lot of those treatments and studies are relatively recent, so we don't have a lot of long-term data. I'm also excited about some of the newer agents that will be combined with our existing immunotherapy agents and with some of our standard treatments. So the triple negative breast cancer is today the cancer that has the shortest survival time, but again, I'm very hopeful that we'll have new treatment. So how do I think about chemotherapy and metastatic disease? And I think that there are different situations in which I might use a different treatment. So I think about what prior treatment the woman received. So for example, if she had a cancer 2, 3, 5 years ago, did she get chemotherapy? That could be if I gave more of it damaging to the heart, the lungs, etc. Does she have other illnesses? Does she have toxicity she's worried about? If she's a pianist, I will try to avoid something that will induce neuropathy, for example. I also consider what prior treatment she received and if she has a residual toxicity, and also preference, whether it's once a week or once a month or other considerations. In general, we try to give one chemo agent at a time, but sometimes we do give a combination. And the reason we give usually one single agent is that it's associated with benefit in most women and less toxicity than if we give a combination. Again, happy to talk about it during the question period. Many times we start with a drug like Taxol, or more recently a Ribolin, or there's a drug called capecitabine or Xeloda, which is really the main pill form drug that we have that we're using. But sometimes I will tell a woman I have a few different treatment options, and these are the pros and cons, and we try to come up with what's the best next step for her at that time. with the knowledge that the other treatments will be available later on. Just as I know I was asked to talk about new treatments, the newest drug for triple negative breast cancer, which is initially provisionally approved in 2020, but more recently in 2021 got full approval, is sacituzumab, or can say that name, Trevely, which is a drug that has shown to improve the time with cancer in triple negative breast cancer. This is one of the first drugs in a long time that we've seen that actually can allow women to live longer. So that's a very successful endpoint. And it's usually given on 2 weeks in a row, and then there's a week break. But it is pretty harsh, I think. There is a lot of gastrointestinal side effects. Diarrhea can be severe, and it also affects our white cell counts, can cause anemia and many other symptoms. So many times the dose and schedule have to be adjusted. So I was going to stop for a moment to see if there are questions about chemotherapy and then move into HER2 therapies.
There's no questions that have appeared thus far.
Great. So HER2 therapy, so about 15, 20 years ago, the HER2 positive breast cancer were considered the most aggressive, because if a woman had a HER2 positive breast cancer, usually the tumor will grow quickly on several types of chemotherapies and will be associated with early deaths in the metastatic setting. But once Herceptin was developed, and then many others, this is now a cancer that women with metastatic disease can live with for years, decades, and again, there are occasional cures. The HER2 is a receptor that sits on the cell lining, and as I said, it's about 15–20% of breast cancer. About half of those will be hormone receptor positive as well. So some cancer can be targeted with hormone therapies and anti-HER2 therapies, and about half of those HER2 positive cancers will be hormone receptor negative, and then will be receiving either the anti-HER2 therapies alone or with chemotherapy. And most of the anti-HER2 therapies have shown that people can live longer with this treatment than without the treatment or with chemotherapy alone. And I wanted to touch on a couple of very new treatment. Tucatinib is a new drug, and I thought I will take the opportunity to maybe share with you what does the data look like that we look at on the scientific side. So this is again one of the newest medication for anti-HER2 positive disease, for HER2 positive disease, and tucatinib is given with trastuzumab, which is Herceptin, and capecitabine Xeloda. So it's two different treatments given against the HER2 positive cells and also with a chemotherapy. So when the studies are done, they compared what's called the standard treatment, and here it's this red line, which is patients receiving a combination of the Xeloda and Herceptin, which is was considered the time standard, and a placebo, and then the treatment arm or the intervention arm is the same, what we call backbone, which is the Herceptin and Xeloda, and then the new medication, in this case, tucatinib, is added. And then usually those large studies will enroll patients from many sites, sometimes from around the world, and then there's a main group that looks at both toxicity and benefit, and they count the number of cancers that progress on the treatment and when the progression is. So what they look at here over months is how many people had progression of the cancer, and what they see is that the people who got this tucatinib in the blue line, there were fewer cancers progressing over time. So that shows what we call significant improvement in the progression. So cancer not progressing, progression-free survival. But also importantly, in the study, they looked at overall survival. So the number of months that people live altogether, regardless of what treatment they received afterwards. And this also showed that there was a survival benefit, and it's been approved by the FDA. Likewise, another medication that has been approved is called Enhertu, which has shown significant benefit. And the thing that I just wanted to mention briefly is it's being now tested in what we call HER2 low cancers, some cancers that are estrogen receptor positive or triple negative today might have low level of HER2, and there are ongoing studies with this drug that show promise. Today, we're able to provide several treatment for HER2 positive disease. What I call first line is usually a combination of a taxane, either Taxol or paclitaxel or docetaxel, Taxol or Taxotere with Herceptin and Perjeta. And I have women I take care of who've been on a combination for many times. I usually drop the chemo part after about 6 months and then keep them on this 2 anti-HER2 medication. I add hormonal therapy if they're hormone receptor positive. I have several women who've been on this treatment for 4 or 5 years. And then TDM1 is a medication that includes a chemo and Herceptin in what's called a conjugate. So those are tied together, and only when they get to the HER2 positive cells are broken down to the chemo and the Herceptin part. So it's actually pretty well tolerated, and there's no hair loss, for example, because it's really driven to the cells that are HER2 positive, the cancer cells. And again, women in my practice have been on this for 2 or more years. And we also have a few studies in combination with this agent. And then there are a few new options, such as the Enhertu we talked about, neratinib and tucatinib, and there are many, many others. Also wanted to mention briefly, and again, I don't have time to talk about each of those, but I wanted to put them up there so you can ask me if you have specific questions. Immunotherapy today is available, meaning FDA approved, only for women who have cancer that's PD-L1 positive, triple negative cancer. And there's 2 medications, atezolizumab, usually given with Taxotere, on pembrolizumab. And genetics is important. BRCA-associated cancer, if you are a BRCA carrier, PARP inhibitors are a benefit. And also, I'm calling those genetics and genomics here. Let me explain. When I think of genetic is whether you have a mutation that you were born with that was passed to you from your father or mother and makes you prone to cancer. So mutations like BRCA make people more susceptible to cancer in a younger age. PARP inhibitors are beneficial, and now we know that you can actually look also at the BRCA status within the cell. There are sophisticated ways to look at the genes within the cell to help guide treatment. So in addition to BRCA, there's mutations, for example, in HER2. I mentioned to you HER2-enriched cancer, but there are cancers who can look under the microscope as hormone receptor positive or triple negative, but they can develop mutation and abnormality in the gene for HER2 in the cancer cells. And for them, we might be able to add anti-HER2 therapies. There's also something called tumor mutation burden. Cancers that has lots of mutations in it may be very responsive to immunotherapy. And then there's other that are not specific treatment for the metastatic breast cancer, but at times surgery and radiation can be considered if one of the areas is bothersome or pressing on an area that's of concern. So, for example, if a woman has cancer that's spread to the bone and has pain, she can have radiation. Or if the bone lesion in the spine is causing nerve-related issues, she could have surgery to decompress that area. Also, women who have cancer that's spread to the bone, we give something called bone modifying agents, which often are also used for osteoporosis to try and make the bone stronger and prevent additional spread of the cancer. And we also have to think of other specific areas of cancer spread. So, for example, brain metastasis, cancer spread to the brain are sometimes a little bit tougher to treat because our medications don't always cross what we call the blood-brain barrier. Unfortunately, cancer cells do, but not all our treatments are. But that could influence our decision. Many of these women will need surgery or radiation. And then the many, many more treatments that I'm just not going to have enough time to talk about today. And then what I call adjunctive medications, medications to help with symptoms if a woman has nausea because of the cancer or the treatment, or low cell counts, might need transfusions or growth factor or pain medications. So let me stop for a minute and see if there are any other questions right now.
There's no questions that have been submitted thus far.
So for the next few minutes, I wanted to tell you about a new clinic that we started. And the reason is that I've just, I'm leaving this slide on to just show you how many possibilities of treatments and additional intervention and support there are for our women. And our feeling is that for women to live as long as possible and as well as possible, it's also important to provide holistic care. And sometimes we're so focused on the treatment, what to do next, that we are not able to provide additional resources when available. So one of the things that my colleagues and I wanted to do is bring some of those potential resources to women earlier in the course of their metastatic breast cancer, so they'll be aware of what else can be done, either by either physicians or clinical teams, or that they can do on their own to try and improve both the time with cancer and living well with cancer. So we started a clinic called Hope at Hopkins, and Karen Smith is one of the lead physician who has been working closely with me. Elizabeth Saylor is one of our navigators, and Christine Hodgdon is a patient advocate who's lived with metastatic HER2 positive, hormone receptor positive breast cancer for a few years. And we have a terrific program coordinator, Jackie, and several helping co-investigators. And we're happy to and thankful to the CDC, NCCN, Pfizer for providing us some of the support. And also, some of you may be aware we hosted a metastatic breast cancer conference at Hopkins in 2018 and had some proceeds, and we're using it to fund the clinic. What are our goals? Our goals are to provide an individualized approach to the care of patients with metastatic breast cancer. Every person and their loved one have a different need than another person. We want to ensure access to optimal assessment, care, resources, and education to build upon the medical oncology care for the patients that they are already receiving, and to promote advanced treatment and wellness. We want to bring to the patient the most advanced treatment options, latest research, but also supportive care that align with their personal goals, future plans, and quality of life. So what are the components? One-on-one navigations. We are still refining our educational resources. Patients receive what we call a supportive care consultation, so they're aware of what other adjunctive medications they are, and if they have questions or concerns about issues that may pertain to them at the end of life, we try to provide the support so they can just think about the issues that are most pertinent to them. And there's other consultation as needed based on where the cancer is or what symptom the woman may have. We also have an integrative medicine provider and a rehabilitation doctor are involved to, again, provide the most holistic care and focus on support, health, and wellness, and also to help coordinate referrals. So, for example, if a woman has interest in spiritual care, we will have our chaplain, if that's what she desires, talking to her. If a lot of our women are young, if they have concerns regarding sexual function, we will have a provider talking about that. So there's a menu that women can choose from and tell us what they're most interested in. And then there's education about potential clinical trial. And one of the medical oncologists, usually Dr. Smith or I, will provide a summary. We're hoping to expand this a little bit. We were hoping to do this in person, but this started during COVID and it's only all been remote. We're still refining the plans. So to summarize what I told you today, there's been a lot of progress in understanding and treating breast cancer. There are many therapies available to women with metastatic breast cancer. Challenges of understanding the evolution of cancer over time and how to best treat it. But I do believe the ongoing future trials will allow us to better make decisions about treatment for individual patients, and by doing so, minimizing both over and under treatment. It's lots of new technologies, ways to analyze data and experiences that, again, hopefully will help us advance the field further. And I wanted to thank you. I want to thank my colleagues at Women's Malignancy Disease Group that helped me think about those issues every day. And I do want to take a moment for Jillian. And a word about Jillian. She's gone through a lot herself, as you know, but she has used both of her own background and beliefs, but also what she learned to better her life with cancer, and also that of many others. And some of the programs that she's done are been very helpful to many women around the country and the world. And ideally, we would want to package it as part of what every woman receives who is diagnosed with cancer. So thank you, Jillian, for being such a pioneer.
Thank you.
Well, I'll stop sharing and take more questions.
Okay. Dr. Stearns, could you start my video? You're the host, so it says.
Oh, gosh. Don't know how to do that.
That's okay. I can start reading some questions. One of the questions that I have here from the audience is the HOPE program open to all or only to the newly diagnosed?
So actually the way we are thinking about it right now is, and part of it is we have an advisory board and they help us think about it, is that, women go through a lot of consideration and decision when there has to be a treatment recommendation. So we suggest the woman goes through the decision-making with her doctor, and then once you started a path, that may be a good time to pause and listen to some of the other consultations. So again, those are geared not towards decision, what should I do now about my cancer treatment, but what else do I need to know about to make sure that my outcome is the best possible one in terms of future treatments and other holistic intervention.
Okay, the next question, it's a bit of a long one, but so I'll start to read. What is the role of a medical oncologist in the metastatic setting, which can present complex challenges, as you note, given treatment options, as well as addressing symptoms from tumors or past treatments? It seems that a medical oncologist would serve as a quarterback, so to speak, overseeing the overall patient needs and bringing in other specialists as necessary, but not sure this is how medical oncologists view their role.
Yeah, I mean, I think that, depending who the medical oncologist and where they practice, there are probably differences, but I personally think that the medical oncologist needs to be the quarterback, but, and actually that's the word we use in our metastatic breast cancer clinic, but there are a lot of challenges, unfortunately, in our healthcare system being fragmented, that we have to reach out to specialists quite often in other departments, and we don't have always the support to support the patient as we're trying to do that. So it's pretty difficult. There also, not everything is related to cancer, so we do need to loop in the primary care doctors. So the ideal situation is the patient has a good relationship with a primary care doctor and the oncologist, and hopefully at least early on in the course, or once there's stabilization and treatment, visits are less often. And again, part of the role of our new clinic is to let the patients know what providers or resources can be available if she needs them. So, for example, I found that our rehabilitation medicine consultant had some ideas for specific women of things we didn't know about. So bringing them a little bit earlier on is going to be important. I'm not sure I completely answered the question, but I do think that the medical oncologist needs to be aware of what's going on with all the patients' issues. Here you are.
Yes, here I am. I appeared. Okay, so we have, I'm going to read a few questions that I received via email. How long does it take breast cancer to metastasize? Months or years? And why can't mammograms detect it earlier for de novo patients?
Yeah, very difficult question. The answer is that it's still evolving, and the same way I've mentioned to you that there are different subtypes of cancer, each cancer biology is different. So some cancers are very slow growing and some are faster growing. So it could be months or years for the appearance of metastasis. So I could see a woman with, let's say, stage 2 breast cancer, and she goes through different treatments and there's no evidence of the cancer. And then 6 months later, something could appear, or 6 years later, something can appear. So the biology is different. So the luminal A's, for example, we talked about, those cancers can come back 15, 20 years later, and it's something we call late recurrences. And then the cancers that are triple negative or HER2 positive, if they were to come back, they would come back usually in the first 3 to 5 years. Now, why cannot mammogram detect that? So unfortunately, mammogram is very good at detecting some of the earlier, slower growing tumors, but many times it misses the larger, sometimes the more aggressive tumors that appear more quickly. So it's not uncommon for women to say, I just had my mammogram and it was normal, and now I have a big mass in my breast and the mammogram doesn't show it. It's not common, but it can happen. And then young women who don't necessarily have a known risk factor or family history haven't had their first mammogram yet and could present with a mass, and sometimes it could be also associated with metastasis. There are also some situations where there is a metastasis, but we can't find anything in the breast, and that's not usual, but it can happen. So mammogram is not perfect, and we don't have a better tool now. MRI is used sometimes really just in women who have mutations or very, very high lifetime risk of breast cancer due to family history or genetic risk.
I have a question, Dr. Stearns.
Sure.
So having metastatic breast cancer myself, I think that one of the emotions that we feel, or I feel, is anxiety. And so what can someone do to alleviate that anxiety by empowering themselves with some tools that they can start to do in their daily lives that will help in maybe preventing progression of the cancer, or to just feel better in general?
Yeah, anxiety is quite common, and fear of the unknown. I mean, none of us can predict what would happen. Cancer, we're hoping for the best. We're hoping for decades and years of the best possible quality of life, but we can be surprised. And even women with the smallest tumors we don't anticipate would come back and surprise us. So women live with fear and anxiety. Overall, I suggest anything that helps reduce inflammation is good to both for healthier mind and improves all outcomes of cancer. So I suggest that women finds what works best for her, whether it's altering her diet. And I don't recommend any strict diets. I think it's really just what's good for your heart kind of diet, so fruit, vegetables, more fish and chicken, less red meat, grains, regular activity, and other ways to alleviate anxiety are mindfulness or other integrative medicine type approaches. And everybody is different what she might be consider also physical activity. There's so many options today, and I think the most important is to find the one that's right for you and you can be consistent with, and then talk to someone, whether some women prefer one-to-one, one prefer a support group. I think that you have to find your own community. And then some women study breast cancer tell me, I don't want to talk to other women studying breast cancer, that makes me more anxious. So one of the things that I'm hoping we can build over the years is have women connect over a common interest or a goal rather than around a type of cancer or stage of their disease, so they can talk about, walking their dogs or climbing mountains or other interests, and not necessarily the day-to-day issues of cancer.
I'm so glad that you said that, because when I was diagnosed with metastatic breast cancer, I joined some support groups, and for me, I felt like it just exasperated the raw emotions that I was experiencing, because the focus was on the negative and not ways to prolong my life and improve my life, to empower myself, things that I can do. So that's one of the things that we really try to focus on with iRise Above, and welcoming in women of all stages, is that we have a lot of living to do, and the focus does not have to be around death. It can be around a lot of things. And so we have the wellness program as an example, our 12-week wellness program. We connect on Mondays on Zoom, and we have topics of conversation, and we're about to launch a book club, which is going to be super exciting. So I completely agree with you on that. Yeah. So I have go ahead. Sorry.
No, I was just going to say that, I think finding what's right for you. And again, not two people are alike, not two stories are alike.
Okay, we have a few more questions. The next question is, do you think mammogram screening should be done in women younger than 40?
So I don't think so. I think a lot of things we look about is risks and benefits, and a mammogram actually is associated with some radiation exposure. And if you start adding the yearly mammograms, especially in younger breasts, it could actually be cancer promoting. And the number of cancers that are diagnosed in women younger than 40 on a mammogram is pretty small. What I hope to see is a more targeted approach. So whether in the future we will have better predictors of who is at the highest risk for breast cancer or should have the tests before the age of 40, women who have relatives at a young age with breast cancer will be screened earlier, and depending on the age, it might not be a mammogram. So it's very complex, but right now the risks versus benefit does not support having a mammogram for an average woman under the age of 40.
Okay. The next question is, would you recommend periodic CAT scans or bone scans for patients who have been treated and sent back to primary care as a way of catching metastases that does not show in a mammogram?
Yeah, so that's a common question. And the answer is we don't recommend any routine imaging studies. We recommend regular physical exam and just regular blood tests. And this is actually coming from very, what I call high level studies where women with early breast cancer either had what we call intensive testing. So they had blood tests and imaging, and then the other group had just regular doctor's visits. And what they found was that the women who've had the regular imaging had more anxiety before the test and fear, and then they were relieved when the test was negative. But then quite often, either something was found between tests or the test led to more tests and biopsies and fear and anxiety. And what they've shown is the women who didn't have this intensive testing had better quality of life, less anxiety, and actually the number of detected cancers that came back and surviving cancer, living long-term with cancer was the same. So it's actually one of our main guideline recommendation not to do testing. Now, having said that, we're very liberal with tests if the woman develops a new symptom. So we guide them and try to give them information before they go to their primary care doctor. If you have anything you're not sure about that is continuous getting worse, that's the kind of thing we want to hear about, and we're very liberal in getting tests there now. I will mention though that there's hope that some of the newer testing, there's a lot of interest in circulating DNA, which is just fingerprints of DNA that may come from the tumor, and whether that could be something they will be used in the future to help us determine who still has some residual cells, and then whether we can use this information to provide another type of treatment. So we're going to hear a lot more about that, I think, in the future. And I'll just mention that in other cancer types, we do testing, but that's because the biology of those cancers is different. So for example, if you have cancer of the colon, if it were to come back, the first place it's going to go to 99% of the time is liver. So if you can find one area in the liver, you can remove it and potentially get rid of that cancer. But in breast cancer, if you find one area, there are usually other areas that you can't see. So therefore, we cannot compare different type of tumors, but look at the evidence from the studies that were done in a specific type of cancer.
Dr. Stearns, I have another question that I'll read from my email. How often should a woman with metastatic breast cancer have her tumor markers or cancer antigen numbers monitored?
So that also has to be individualized. So first, not every woman who has metastatic breast cancer will have elevated markers. So the first question is, are the markers elevated? And then if they're elevated, do they correspond to an early change on a CAT scan or PET scan or another type of imaging? So for example, if a woman presents with a new metastatic breast cancer and the marker is a little bit elevated, and then we start a new treatment and 2 or 3 months later, the marker is normal and the CAT scan is better, that's a marker that we can use over time to decide how often to do the scans. But in some women, as I said, it is not elevated. In some women, it doesn't correspond to the scan. And in general, we like to consider a change in treatment if there's a change in the anatomy of the cancer, the number of cancer metastasis or the appearance of new metastasis, and not just based on a number. The tumor marker is basically a protein that the cancer sheds. So it's sometimes just almost like a warning sign that the cancer is becoming more active. But it can, give us a little time to consider other treatments or clinical trials, especially if a woman wants to travel and consider other clinical trials. So I wouldn't just change a treatment based on a number.
But is it standard, Dr. Stearns, that most women at least once a year will have her tumor markers monitored?
I would say that I individualize it. There are some women that I do it, monthly early on and then spread a little bit. And then if they've had stable disease for a while, I might do it every 3-6 months or even once a year. Yes. And there's some women that if it hasn't correlated with the scans early on, I might never do it.
Okay. We have another question from the audience. Can you provide any interesting updates from ASCO?
ASCO, yeah. So this was just this weekend. Probably the most what we call practice changing news came from a study in earlier stages, not in metastatic disease, which was in women who are BRCA carriers who have an early breast cancer, who got their surgery and radiation and chemo. If they get a year of a PARP inhibitor, there are fewer cancer recurrences. And this is important both because we're going to start prescribing those medications to those women, but also that I believe the genetic testing should become universal. And having said that, every woman with metastatic breast cancer should have genetic testing. And it's not always the case. I mean, I would see sometimes a woman in a consult and she may be a little bit older and hasn't had a family history and wasn't tested. And we will test her on the spot because their potential treatment just for her. Other news were related to new immunotherapies, et cetera, but there's nothing that would say is a change today in our practice.
Okay, is there any more questions from the audience? If not, we'll wrap up. It's 1 o'clock. This has been wonderful. Thank you so much, Dr. Stearns. I really appreciate you making the time in your busy schedule to speak to us about these updates. I think the more information we have, the better. So thank you very much.
My pleasure. Thank you, everyone, for listening.
All right, have a wonderful day. Thank you, everyone.
Take care. Bye-bye.